So we're now talking about traumatic brain injury that has occurred as a result of trauma. Now these are very common, but fortunately most of them are mild. So of those admitted to A&E departments, probably a good 75% are going to be a fairly mild level of trauma. But some are moderate, and as we see with the moderate, the Glasgow Coma scales are going to be 12 to 9, between 12 and 9, as opposed to just below normal levels of Glasgow Coma scale with the mild head injuries at between 15 and 13. But if the Glasgow Coma scale is 8 or less, this would be classified as a severe head injury, severe traumatic brain injury. And everyone would agree, I think, that a severe injury, the patient is unconscious and unable to follow commands. So severe injuries, unconscious patient, unable to follow commands, low Glasgow Coma scale, probably 8 or less. To understand head injuries properly, we need to know a little bit about intracranial pressure, the pressure within the cranial cavity. And this goes back to the early years, actually, of the 1800s, even before 1850, with the Munro Kelly hypothesis or the Munro Kelly doctrine, formulated by Monroe and Kelly way back then. And this is based on the idea that the cranial bones form the cranial cavity, and that inside there is a closed vault. It's completely closed inside here. And this is fairly obvious when you think about it, because if you feel your head, there's no gaps. It's a closed cavity. The cranial cavity is surrounded by the cranial bones. And of course, I know there's gaps on the bottom, but in life these are filled with connective tissue, neurological tissue, and blood vessels. So the cranial cavity, which we can see if we open this skull, the cranial cavity is completely surrounded. It is a closed vault. And that's important because it means that no expansion is possible. It can't expand. So like if you get an injury to your abdomen, your tummy can start sticking out, but this can't because it's bone and it won't expand. Now the intracranial cavity is around about, in an average adult, about 1450 mils, something like that. And Munro Kelly rounded these figures off. They said that the brain occupies about 80% of intracranial volume, that blood occupies about 10% of intracranial volume, and that the cerebrospinal fluid occupies about 10%. So it's 80, 10, 10. More accurate modern figures might be that the brain is about 1300 mils, that the blood is about 110 mils of intracranial volume, and the cerebrospinal fluid is a bit less, at 65 mils. But you know, the Munro Kelly figures are rounded off, and they're still quite useful. And this means that if there's anything that takes up space inside the cranial cavity, then if the volume increases, if the volume of one part increases, it means that the volume of something else has got to decrease. So any increase in volume within the cranial cavity must be compensated for by reduction in the volume of another component. Otherwise, the intracranial pressure is going to start rising. And this is the Munro Kelly idea. Any increase in the volume within the cranial cavity must be compensated for by decrease in another component, or intracranial pressure will start to rise. Now, anything that takes up space inside the cranial cavity, which is not supposed to be there, is called a SOL, a space-occupying lesion. For example, after an injury, a blood clot could start developing. That's not supposed to be there. It's going to take up space, so the volumes of other components in the cranial cavity must reduce, otherwise intracranial pressure will rise. And what you actually find is that the compensatory mechanisms allow for an increase of about 100 to 120 mils. So if you're bleeding, someone's bleeding into the cranial cavity, 50, 60 mils of blood can go in without a significant increase in intracranial pressure. And up to 100 or 120 mils of blood can go in, forming a space-occupying lesion of that size without a significant rise in intracranial pressure. And the reason for this is that there are compensatory mechanisms. And the main compensatory mechanism is displacement of the cerebrospinal fluid. So if we think about the brain here and the spinal cord, well, we know that this is surrounded by the dura mater. The brain and spinal cord surrounded by the dura mater. Underneath that is the arachnoid and the cerebrospinal fluid. And if there's a space-occupying lesion developing in here, taking up space, then what will actually happen is cerebrospinal fluid will be displaced down into the dural sac. And actually the dura mater is thinner down here than it is up here, so you can get some fluid displacing down, meaning that the pressure here will not rise significantly. But if the space-occupying lesion gets bigger than 100 to 120 mils, then the compensatory mechanism will fail, there'll be decompensation, and intracranial pressure will start to rise. Let's carry on thinking about intracranial pressure, the pressure within the cranial cavity. Now, intracranial pressure is dynamic. It's going to vary depending on the position the body is in and how you're breathing and whether you're coughing or not. So normally 0 to 10 or 0 to 15 is considered roundabout normal when the patient's lying down. So when you're lying down, there's going to be more intracranial pressure. When you stand up, it's going to be less. So we can normally say that less than 10 to 15 millimetres of intracranial pressure is normal when the patient is lying flat. And in children, these values will be less than that. Now, if anything's causing the intracranial pressure to rise, if it's sustained above 15 millimetres of mercury, this is termed intracranial hypertension, high pressure. High pressure within the cranial cavity. And if it's maintained at high levels for a long period of time, there can be focal levels of ischemia developing. So here we have the blood vessels going through the brain, and if the intracranial pressure is higher than 20 millimetres of mercury over a period of time, this intracranial pressure is going to push down onto these blood vessels, and it's going to tend to squeeze these blood vessels shut. And that is going to cause areas of brain ischemia. So raised intracranial pressure will start to close off the blood vessels, resulting in brain ischemia and the potential for brain damage. Now there'll be global ischemia to the brain if the intracranial pressure rises probably around about more than 40 or 50 millimetres of mercury. And in fact, figures of 40 or 50 or more millimetres of mercury become life-threatening. And at these levels, the Glasgow Coma Scale would drop off significantly and the patient would have a very low level of consciousness. So normally treat intracranial pressure if it rises above 20 to 25 millimetres of mercury, and levels of 40 to 50 are severe and will lower the Glasgow Coma Scale and can eventually become life-threatening.